Thank you. First of all, I'd like to thank you all for listening. Thank you for all of the support of the community and the advocacy organizations, PPMD, that has really helped very much in bringing this program forward. With Catabasis, now that we have a name, it's kind of like a growing up phase of a drug. So I need to show you a forward-looking statement for at least a few seconds. And also to disclose that this is an investigational agent. It is not yet approved in any country. And I'm an employee of Catabasis. So we think that Catabasis is potentially a disease-modifying oral therapy for Duchenne. And we think that this could be effective across age groups and across all mutations as well. It's an oral agent. The capsules, they're soft gel capsules that are shown there on the left. The molecule targets a pathway, NF-kappa B, that you just heard Eric talk about. And we believe that that is central to the pathophysiology and how the disease progresses. We have shown, working with Professor Lee Sweeney at Florida and CHOP, we've shown positive effects on skeletal muscle in animal models, and also in respiratory muscles, the diaphragm and cardiac muscle, all in preclinical models. We have completed phase 1 studies, and we have shown an effect on NF-kappa B in those studies in adults. And we've also completed the first part of our clinical trial that looks at whether or not we see these effects on NF-kappa B in boys, and we're pleased to say that we have been able to see that in the boys that we've studied so far. So the second part of this study, it's called the MOVE DMD study, is ongoing right now. So why are we developing Catabasis? As you all very well know, in Duchenne, it's the lack of dystrophin that's central to the disease. But it's not just the lack of dystrophin, because you know the muscles are intact at a young age and have appropriate power and ability. But what happens is that dystrophin is basically a shock absorber protein. So in the absence of dystrophin, mechanical stress is the muscle is unable to protect itself. So this activates this protein complex called NF-kappa B, and the activation of NF-kappa B leads to inflammation, it leads to fibrosis, muscle degeneration, and ultimately the replacement with fat and fibrosis that leads to loss of function of the muscle. We know, as you just heard, steroids suppress inflammation. They're very good at it, but they have significant side effects, as you've heard. So this shows the central role of NF-kappa B. And the absence of dystrophin, along with mechanical stress that prevents protection of the muscle now, activates NF-kappa B. And several things happen when NF-kappa B is activated. In the center is shown it activates a number of proteins, a cascade of proteins that affect inflammation and ultimately fibrosis in muscle. On the left, NF-kappa B also directly impacts the synthesis of muscle proteins, and it also affects or also increases the degradation of muscle protein. And on the right, another very important effect of activation of NF-kappa B is also that it prevents muscles from regenerating, prevents muscle stem cell proliferation. And that's very important because the muscles are continuing to be damaged by the mechanical stress. So in fact, Eric showed almost 15 years ago that NF-kappa B is activated in infancy. You can see it even in very young babies, you can see the activation. And that happens even before the other things that happen in the disease, before the start of fibrosis, before the start of loss of function. And in animal models that really target, well, what happens if you specifically target NF-kappa B? Because that's what we want to know here. We have a very specific way of targeting it. And if we reduce that, will we reduce the damage from the activation of NF-kappa B? And a couple of ways that's been looked at in animal models is to look at basically a knockout. So to look at an animal that has one less of the two normal genes for NF-kappa B. So it has a 50% reduction in the amount of NF-kappa B. And when you look at that in the mouse model, the standard MDX model, you see even a 50% reduction has significant improvement in the phenotype, in the way that the mouse looks and in the morphology when you look at it under a microscope. So that the mice have improvements in their muscle mass and their function. So we know that very specifically if you hit NF-kappa B, you can have an effect. And another more recent effect that Eric has shown is if you have some dystrophin function, then if you inhibit NF-kappa B, then it prevents the synthesis of more dystrophin. So if we could look at this even with dystrophin-targeted therapies, it could potentially have a positive effect in combination. And ultimately, we know that combination therapies is probably where we need to go with this disease. So that the effect on stem cells is shown on the left side of the slide. And the top is an MDX model where stem cells are infused, and you can see the red outlines of dystrophin production there. And in the bottom slide, that is a mouse where there is a 50% reduction in NF-kappa B. And you don't need statistics to see that there is an enormous increase in the capability of the stem cell to multiply and regenerate. So we are using, in our studies, magnetic resonance imaging. You heard Dr. Krista Vandenborn speak about it yesterday. It's an incredibly powerful technique that they have been able to develop with a natural history study that has gone on for now over 5 years. And with the help of the community and volunteering for that study, a natural history study, not an intervention study, they've really been able to understand a great deal more in terms of what happens in the muscle and how you can visualize it. And to the end of how can you look at this in a clinical trial in order to make the clinical trial process faster and ultimately get a drug approved faster. So I don't think, do I have a pointer here? No, I don't have a pointer here. So on the left is the muscle from, it's a cross-section of the thigh of a boy around 12 years old. And you're looking cross-sectionally, so the dark part is the muscle, and it's very homogeneous, it's intact. And on the right are muscles of the thigh of a boy age 14 with Duchenne. And there you can see in the back and in the left side, the muscles are largely replaced with fat and fibrosis with the effects on function that you well know. But there are two muscles that are not affected. The muscles on the side there with the red arrows are called the gracilis and the sartorius. And we know those muscles are not inflamed early when you look at them at age 5 or 6, and then they're relatively preserved later. Those muscles are intact. And those muscles are not muscles that are terribly mechanically stressed. They're more twisting muscles. And we think that's part of why they're intact at this later stage. So we're going to use MR to be able to look at the progression in the clinical trial. So we think that CAT 1004, edeselinexant, can have effects by blocking activation of NF-kappa B. And we've shown this to date in animal models where we've seen reduced muscle degeneration, reduced inflammation and fibrosis, and we've seen that there is an enhancement of muscle regeneration as well in all of the muscles, both skeletal as well as cardiac. We've also seen that the pharmacokinetics, how the drug is distributed, it tends to be more distributed in muscle. So we think that this is all good signs in terms of moving forward. And while steroids have an important effect on inflammation and fibrosis, they actually also have negative effects on protein synthesis in muscle and very importantly have negative effects on muscle regeneration. So if you heard, the net effects of steroids are positive, but it's probably a balance between the negative effects we see with steroids in other diseases and the positive effects that it has on inflammation. So we want to take the best of that and bring it forward to develop a drug for Duchenne. So the first thing we did was, after we did the appropriate animal studies, was take the drug into phase 1, and in 3 trials in healthy adults, we looked at single and multiple doses, as well as a biomarker study. We did not see safety signals, and we saw that the drug was well tolerated. We also saw that there was reduced expression of genes that are targeted by NF-kappa B. So we were able to look at that after 2 weeks of dosing and see in peripheral white cells that those genes were reduced. We were also able to look after a single dose, and etaselenexant is actually composed of 2 simple molecules that are linked by a 3rd molecule, salicylate and the omega-3 fatty acid DHA. They're linked in a very particular way to allow them to be released intercellularly and have a more than additive effect on NF-kappa B. So in the clinical trial, what we looked at was the effect on white cells of NF-kappa B, both with placebo, with a single dose of etaselenexant, as well as a single dose of salicylate and omega-3 fatty acid. And we saw there was a 70% reduction in the protein levels in the white cells. So in both of these studies, we're able to show that we are targeting NF-kappa B in adults. We then we designed the study in conjunction with imaging DMD. This is actually the first study that is using MR as the primary endpoint. And what Professor Lee Sweeney came to us and said, look, we've been able to see that there is an effect of steroids in 12 weeks. So we can use this as a biomarker to be able to see whether a drug is working in 12 weeks, particularly one that's targeting NF-kappa B. So on the right is shown what they showed in a study in boys in the natural history study that were starting on corticosteroids. And the measure is called T2. It's a measure of muscle damage. And the yellow bar shows that when corticosteroids were started, 3 months later there was a reduction in this T2 signal. And in the boys who were not started on corticosteroids, they had an increase in the T2, small increase. And as Eric mentioned, it's really important to be able to see things in small numbers of boys, because we don't want to do a trial with 100 kids to understand it. So this was able to see a difference with 5 boys versus 11 boys that were not started. So this was the basis really for the design of the study. And this T2 marker is correlated over their much larger group of boys that they've looked at. It's correlated with functional measures, time functional tests. So we know that it correlates with true disease progression. It's tricky. So the design of the study is shown here. And what we tried to do in 2 parts was first, take it into boys for the first time and understand the safety. Make sure we have the right doses. That part is complete. And now we're doing the second part of the study with a randomized double-blind placebo control to look at the effect on biomarkers, the biomarker in particular of MRI. So in the first part of the study, we looked at 1 week of treatment in up to 18 boys, 6 boys at each dose level. And we very carefully followed the boys for safety. We also measured the amount of blood, the amount of etaselenexant in the blood, so we could make sure that we were at the levels where we saw effects in adults. The second part of the study is then to look at efficacy, both looking at the MR signal, but also looking at time functional tests that are appropriate to this age group, which include 10-meter walk-run, 4-step climb, and North Star, time to stand, and muscle strength measures as well. Now, because there's overlap in the mechanism of etaselenexant and steroids that both target NF-kappa B, we're looking at younger boys that have not yet started on steroids predominantly. So the inclusion criteria includes a genetic diagnosis of Duchenne, ambulatory boys between 4 and 8, and that are adequately immunized up to date. They have to not have been on steroids for the previous 6 months. Most of the boys, in fact, have never been on steroids. And we also look at labs to make sure, from a safety point of view, there's no issues in terms of liver function or kidney function, or any other drugs that would interfere. So the tests that we are using include MR, which really, as you heard yesterday, is very exciting. Okay, as well as the functional endpoints. So we're looking at that, the MR at the beginning and at the end of the 12 weeks of dosing. We're looking at the time functional tests on an every month basis. And we're also looking at them at the beginning of Part A, so we'll be able to compare them over time. The MR is done without sedation. This shows the boy and basically their leg is on a stable platform, and they have to stay still for about half hour to look at the lower leg and another half hour to look at the upper leg. They've hooked up systems at all of our sites to be able to show them movies, and as somebody put it, it's kind of like video sedation. The boys seem to be very good, and the sites have just done an awesome job in being able to use MR to look at the progression of the disease in young boys. So they've done a great job. So in the first part of the study, the drug was was generally well tolerated. There was no serious adverse events, no discontinuations. And really importantly, we're talking about 4-year-olds. They were able to take those capsules. The capsules we had 2 sizes, about 2/3 of the size of a Tic Tac, 2/3 of the size of an M&M. And all of the boys who are taking them now are taking the larger size. Once they got the hang of it, they did great. And it was wonderful to see. I think people were worried about that at the beginning. The adverse events that we've seen were predominantly mild. Most common was diarrhea. Yes. And the most common adverse events are shown at the bottom. No laboratory abnormalities. We were able to see that in the boys with Duchenne, we were able to see an effect on NF-kappa B. So we looked at 3 doses. The top 2 doses, 67 and 100 milligrams per kilogram, we saw levels, as shown there, above the dotted line. And the dotted line is where we thought we needed to get to in terms of the level in which to target NF-kappa B in adults. And at both those levels, we were able to see effects on the genes targeted by NF-kappa B. So those are the doses we're looking at in Part B. And this study is ongoing right now. It's actively recruiting. In addition to the boys in the first part, we're enrolling an additional group of boys. The sites are the University of Florida, Portland, CHOP in Philadelphia, Nemours in Orlando, and UCLA. And the same endpoints that we've talked about, and that we expect to have the data at the end of the year. So to summarize, we haven't seen safety issues to date. We've seen good exposure of the drug, and we've seen targeting of NF-kappa B in the boys. So after this study, a placebo-controlled study, we anticipate that all of the boys who are on placebo will continue on etaselenexant, and we're also putting into place an open-label extension so that boys can be dosed for an additional 36 weeks. So we think that this can be effective across mutations and at all ages. And to that end, we're also working on planning a study in non-ambulatory boys, where we know that there are a significant number of boys that are no longer on steroids. So we're working with experts to be able to design that study as well. So with that, I'll close, and thank you for your attention.